guest for joining us, and thank you, Mr. Watts, for agreeing to be our guest, and Antonio for leading this conversation. We're really excited about it, and this is such a hugely important topic to all of us. I am looking forward to learning more about what is happening at the National Healthcare for the Homeless Council. It's something we talk about often with our team members and our supporters. Unfortunately, Lee couldn't join us today. She typically spends some time giving a very brief update on, the big theme for the month. And we're just in the process of opening and leasing up SP7, which is the fourth real estate development project to open this year. We've opened Floor 401 Lofts and 649 Lofts, and LA Christian Health Center has opened their new Joshua House Clinic, which was developed by the Trust, and we are now opening SP7. And so this is a tremendously important year. We're bringing 254 of our unhoused neighbors home, and could not be more proud to be the developer on LA Christian Health Center's new clinic, which is 25,000 square foot state-of-the-art clinic serving, the entire community and desperately needed by our residents and our unhoused neighbors. So we're big on accomplishments this year. And at the end of the meeting, I'll share some more information with you about our gala, but that is our big annual opportunity to celebrate our achievements and come together as a community with our supporters and funders, and share our work and help engage people in supporting the work that our team members do day in and day out. And we're just thrilled about it. And so with that, I will turn it over to Antonio and look forward to hearing his conversation with Mr. Watts.
Thank you, Jet. And welcome, everyone. Good afternoon. I'm really looking forward to my conversation with Mr. Watts. First, let me tell you a little bit about Mr. Watts before we jump into the conversation. Bobby Watts is the Chief Executive Officer of the National Healthcare for the Homelessness Council, which supports the 300 federally funded healthcare for the homeless programs and 100 medical respite providers with training, technical assistance, sharing of best practices, research, publications, and active policy and advocacy programs working to eliminate homelessness. Bobby has 30 years of experience in administration, direct service, and implementation of homeless health services. Beginning as a live-in counselor at the New York City Rescue Mission, he spent most of his career prior to joining the council at Care for the Homeless, which operates clinics, shelters, and conducts policy analysis and advocacy in New York City, beginning as an intern and serving as the executive director from 2005 to 2017. Under his tenure, the federally qualified health center agency tripled in size, adding major programs and initiatives, including constructing and operating a shelter for 200 mentally ill and medically frail women, and becoming licensed as a diagnostic and treatment center in New York State. He has served on numerous boards, government-appointed task forces, and work groups, including serving as the finance officer for the New York City HIV Health and Human Services Planning Council and the New York State DOH Medicare Redesign Team's Affordable Housing Work Group and Value-Based Payment Work Group on CBOs and Social Determinants of Health, and as an inaugural member of the New York State Interagency Council on Homelessness, where he co-chaired its health committee. In February 2021, he was appointed as a member of the Biden-Harris administration's COVID-19 Health Equity Task Force. He is a graduate of Cornell University and the Columbia University Mellon School of Public Health, from which he holds a Master's of Public Health degree in Health Administration and a Master's of Science degree in Epidemiology. He also earned a Certificate of Theological Studies from Alliance Theological Seminary in Nyack, New York. Quite an impressive biography, and with that, we're going to jump right in. Mr. Watts, you have over 30 years of experience in homeless health services. Can you share more about your professional background before your current position as CEO of the National Healthcare for Homeless Council? I'm having
Can you hear me
audio.
now?
Now I can. Thank you so
Okay,
much.
thank you. Thank you. And thank you very much for that very gracious introduction. It sounded a lot better coming from your lips than I've heard from many. So thank you. Yeah, I feel really extremely fortunate, blessed to have had the career that I've had. And in many ways, it was an accidental career. I deferred starting graduate school in public health for with the idea for 1 year that I would work at a rescue mission as a living counselor. It ended up being 2 years, and that really gave me my definition for the next few years. Where when I was in school, anytime I had an opportunity to take an elective or do a paper, I would do it around healthcare for people experiencing homelessness. And that led me to, I was fortunate, this was just when the healthcare for the homeless program was starting as a national demonstration project. And one of the sites in New York was our clinic. Excuse me, was our shelter. So part of my job was to get the guys ready to maintain the waiting list for people to come see the doctor that came twice a week. Say to one guy, like, don't leave the doc, I want the doctor to take a look at that infection in your leg. So don't leave, make sure you're back here. And I eventually did an internship with that same agency, which became Care for the Homeless in New York. And I stayed there for 2 years, told my boss I would stay there for 2 years and then leave. I did leave to go to seminary, and with the intent, my wife is a social worker, we were going to work overseas, but health conditions of our kids, childhood asthma, didn't make that possible. So went back to Care for the Homeless and was there for the next 20 plus years until I left 4 years ago to come to the council. So I feel extremely fortunate to have been part of this movement when it was just beginning, to be part of an agency when it was just starting. Began as an intern and basically held every administrative job up until when my mentor, Susan Nybacher, unfortunately passed away, and I was fortunately in place to serve as acting executive director, and then was appointed a few months later to executive director. So that's been this arc of my career. We're chatting. Unlike you, we've had many different agencies. I've had different roles within one agency up until now.
Well, it can never be underestimated that really understanding at every level of how an organization and agency works, and having that direct contact with the recipients of the services that so many agencies provide, that can't be underestimated at all. So I think it's a very interesting journey, and one that I'm sure serves you well in your current role also. My understanding is National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. Can you talk more about what your organization does specifically?
Yes, certainly. There's two ways to answer it, and I'll answer it in both ways. One is a purely technical answer. We provide a great deal of training and technical assistance to federally qualified health centers that have all of them, but especially those that have a special emphasis on serving people without homes. So there are about 1,400 federally qualified health centers, community health centers, and in that funding stream, there are about 300 that get special funding and have special requirements that they have to meet to serve people experiencing homelessness. So we support them with training, technical assistance, advocacy. We also support the 100 plus, now it's about 120 medical respite programs throughout the country. And very briefly, and I know Skid Row has been involved with medical respite with LA Christian Health Centers, and I've been to Joshua Clinic when it was under formation, when it was still under construction, and just so thrilled the role that Skid Row Housing Trust had in making that a reality. But medical respite is, very briefly, for people experiencing homelessness who no longer have a clinical reason to stay in a hospital, but they are not well enough to heal in a shelter, and certainly not on the streets or on a friend's couch. So medical respite is that safe place for them to heal which if it was not there, and where it's not there, people, their health condition deteriorates, they end up back in the hospital, back in the emergency room, back being readmitted with more complications. So this breaks that cycle. So we support those. That's the technical thing of what we do, and we do a lot of policy and advocacy. We have a policy team in Baltimore, so they can be close to DC, where a lot of, since most of our programs are federally funded. But what we really are is a loving, supportive community where we learn from each other, share each other. And the council is that vessel where we convene, where people come together, share on various committees what they're struggling with, what works, what didn't. Very sharing. We shorten the learning curve by freely sharing what didn't work, so help others avoid the mistakes. And that's what we do. Our secret sauce is we just are sharing and supportive of each other.
Thank you for that. And thank you for sharing it from both of those lenses. As I listened to you, of course, I was able to track the very specific things that you do, but the other lens in which you responded really brought the heart to it. And I think that's so important.
And I will add, in my Care for the Homeless, the founder of my former organization was also one of the founders of the council. So from the very beginning was always involved with the council, and really attribute my former agency's growth to the community that the council provided. So I say there was no organization, no job that would have made me leave my previous job and New York City, where I grew up and worked my whole career, except for the council, because I had direct involvement with how important it was.
That's awesome. You know, what do you find are the most crucial health services needed by people experiencing homelessness, and how have these services evolved throughout your career?
One of the ways it's evolved throughout my career is, and I began in the, over 30 years ago in the 1980s, was when I lived at the rescue mission, and have seen, unfortunately, the growth of mass homelessness in this country. At that point, most of the people experiencing homelessness were single adult men, generally older. Now, of course, it is of all age ranges, and now we have a large number of homeless families. To a degree that was not true 35 years ago. We also have an increase in elderly people who are experiencing homelessness that are older, and generally because of the effects of homelessness on the aging process. Someone is considered elderly as a homeless person when they are maybe 50, 55. There are a number of programs targeted to elderly people experiencing homelessness, and that's generally the age cutoff. We know that the effects of homelessness leads to not only poor health, but premature death. The average age of those who die while experiencing unsheltered homelessness is about 25 years younger than the general population in the US, about 50 compared to like 75 in the general population.
Wow. When you think of the services that are needed now, what do you think is most crucial?
Yes, I didn't answer that part. I'm sorry.
Before you answer that, there's someone who has their camera active. We are recording this, so if you don't want to be on camera, if you could go off of video, that would be great. Thank you so much. Okay, Mr. Watts, go on, please.
Yeah, the one things that healthcare for the homeless programs all have to do, in addition to primary healthcare and the screening and prevention and education, all of those are important. We also, unlike regular community health centers, we are required to provide behavioral health services, mental health services, and substance use disorder services. So I would say, especially among single adults, those not experiencing family homelessness, those are really super important issues. And I will say that healthcare for the homeless providers have been leading the way across the country in introducing medication-assisted treatment, one of the state-of-the-art treatment for substance use disorders, for opioid disorders, and in integrated whole health care. Now, it's not considered healthcare, but really, our providers say the number one prescription they wish they could write is housing. And so where they can help link housing, that is the strongest social determinant of health. And we really view that housing is healthcare as part of our ethos. So we really are committed to that. So these basic primary health care, but also the targeted services, especially for single adults, of effective integrated care for behavioral health and mental health services, or substance use disorder and disorders and mental health services.
Thank you. Over the past 2 years, we've all been through and are still in a pandemic. And there's also been a meaningful movement in the dismantling of systematic racism. How has homeless health services and your organization's objectives shifted in response to these watershed moments?
I have rarely been so pleased with the response of an organization I've been affiliated with as I have been with the council's response in the last 2 years to COVID. In many ways, everything we did remained the same with a few exceptions, and we just shifted the focus to COVID, but we were able to shift on a dime as our community's needs were changing in response to COVID. So we, again, helped each other learn from each other quickly, shorten the learning curve. What is one organization facing in San Francisco is also very common with what an organization might be facing in Austin, Texas, and helping them learn from each other. We also had some special policy initiatives. Excuse me, I got a notice that you're having difficulty hearing me. Can you hear me fine?
Erica, can you confirm that Mr. Watts can be heard fine?
Yeah, you can be heard fine.
Okay, I'll ignore that warning then. Thank you. One of the key things was policy, where we really shown, and we had some connections with CDC and HUD, but those connections got strengthened as they began to recognize, the expertise in the healthcare for the homeless and medical respite community, and called upon us to say, what should we be doing to protect the health of people experiencing homelessness in this pandemic? And because we're connected to our community, we were able to bring forth their experiences, and we're able to bring forth our analysis to shape that. And many of our recommendations were included in guidances that CDC and HUD issued to states and localities about what should be done to protect the health of people experiencing homelessness. And we continue to bring forth that expertise and our policy analysis. As far as people experiencing racism, I have been very fortunate that my mentor at Care for the Homeless was one of the first people I heard repeatedly say that homelessness is a result of racism in this country. And certainly the way it is represented and who comprises people experiencing homelessness in this country is a direct result of racism. And I remember when I was at the rescue mission, watching the population shift before my eyes in my 2 years there as a living counselor, from mostly older white alcoholics. This was right when the crack epidemic was hitting, and then watching it change to younger African-American, Latinx men. They only served men. And then seeing who was coming in from prison, being released from prison. And when I was the first data entry person as an intern, putting in the homeless encounters from the medical teams, so often was Black male single, Latinx male single, and it just became looking at it from an individual and then looking at it from a quantitative data point of view. 13% of people in this country are African American. They comprise over 40% of people experiencing homelessness. And we have the same ratio, or perhaps even higher, for Native Americans. When we look at the history of slavery, we look at the history of of broken treaties, stolen lands. how the conditions are on the reservations, it's no accident that we find this overrepresentation. When I joined this, when I interviewed for the council, because of the work I was doing with my previous agency around addressing racism and homelessness, I said if we weren't serious about addressing racism as a cause of homelessness, I was not interested, and the board was completely on board. So we began working on this in 2017, early 2017, when I joined. And so when it came to the more people in the country being aware, we had already been working on this for a few years when George Floyd was murdered, and many people became aware. So our program didn't change with that. It just became more intensified about how we can address racism as a cause of homelessness and address systemic structural racism.
Thank you for that response. You were appointed to the Biden-Harris administration's 12-person COVID-19 Equity Task Force. What was it like to be asked to join and work with the administration?
Well, I was thrilled and completely honored. And when I received the phone call asking me would I be interested, I said yes, of course. And as a public health professional, extremely honored to be asked to bring the expertise of the healthcare for the homeless community to bear on the greatest public health crisis of not just our generation, the last 100 years, and was really impressed and grateful that the administration wanted to bring the expertise and to take into consideration the experiences and how can we protect the health of people experiencing homelessness, and brought forth that perspective also of migrant health workers, of people in prison. The task force members that were asked to be part of this effort, really diverse, bringing a really diverse set of expertise and experiences and perspectives. We have a hospital CEO in a rural area. We have the head of a nurses union. We have learned so much from my colleague who is head of a federation of Native Indian tribes based in Alaska, bringing that perspective. So it's been an extremely rich perspective, rich experience from the perspectives and the expertise of people that have that are part of this.
Awesome. That reminds me, as you were describing who's at the table, it made me think of my days in community participatory research, and that idea of how important it is to have not just diverse perspectives, but the diverse expertise and all the different angles at the table, because you can be tackling an issue, and if you're not tackling it comprehensive, you get blindsided by those things and issues that were never brought to the table that you're now distracted trying to respond to as well. So it's very exciting to hear your description of the task force. What is the task force's mission, and what does it look like to accomplish?
Mm-hmm. So the mission is to make recommendations so that the nation's response to COVID-19 would be both effective and equitable. And that is really our focus on effectiveness and especially equitable. So this present pandemic, as well as to make recommendations on how we can be better prepared so we can have an equitable response to future pandemics. So our work has been done over the last 7 months, and we are getting ready to have our 7th public meeting tomorrow. And we focused on one topic area each month. The first one was data. We've looked at behavioral health. We've looked at we've looked at xenophobia, discrimination and xenophobia. So each month we meet in committees, go through a process of identifying the top problems and then coming up with recommendations for those in an iterative process. So at the end of each of the monthly meetings, we've made interim recommendations that are sent immediately to the White House. And I was informed yesterday when we're having a preparatory meeting for tomorrow's meeting that 42% of our interim recommendations have been implemented or are in process. So it was really important, I think, to everyone on the task force. We want to make long-term recommendations, but we also felt the urgency that we wanted to have immediate response. So we've talked about vaccines, testing and PPE were also some of the topics, and these were things that were happening right then and there, where we saw so much inequity that we wanted to have a way of addressing and making recommendations.
So I've listened to you describe your experience in your organization, and if I've been taking this in correctly, what I come away with is that your organization, what makes it unique is that your programs have varying organizational structures. You deliver your services everywhere from standalone programs, local health departments, to larger community hospitals, to name a few. Additionally, healthcare for the homeless programs receive 8.7% of healthcare program funds. So what's next for National Healthcare for the Homelessness Council to accomplish that it hasn't accomplished yet?
Yeah, I'm always thinking of I'm a half empty, glass half empty kind of person. I always say, what else can we do? How can we make this better? So I think some of the key areas where we can, what is next? What is before us right now is we finished a strategic planning process right before the pandemic. And fortunately, we've been able to hold true to those, but one of them was to expand medical respite. The need for medical respite is much greater than our current supply. So we, as part of our strategic planning process, we said in July of 2021, a few months ago, we were going to launch an institute that now it's called the National Institute for Medical Respite Care. When COVID hit, there was so much interest and request from people saying, we know medical respite is part of the solution to meeting the needs of people experiencing homelessness in the pandemic, that we fast forwarded that and we launched it in July of 2020. Since then, it succeeded in elevating the profile for garnering resources and expertise so we can support medical respite programs more. We've received funding that we've been able to re-grant to support medical respite programs around the country, probably in the neighborhood of like over $3 million in the last 18 months to beef them up because they're so much. So we want to continue that. In 2016, the council created standards that were approved by HRSA on these are what good quality care is in a medical respite program. We've just updated those standards. They're going to be released and published any day now. So our goal is to continue to advance the practice and expand the practice of medical respite because the need is so great, and it helps the health system, it helps individuals, it helps the whole homelessness response system. Another area we want to continue to improve or to advance is our work around race equity. We feel very fortunate that we are considered to be leaders, and the phrase I use is, in a land of the blind, a one-eyed man is king. So we began working on this a few years before many people were interested in it. And we certainly are been sincere and have made great strides and help our community make strides. But we have so much far to go. And I'm always aware of how much we don't know. So want to continue getting information and then sharing it with our community, helping them learn how can they, so far our focus has been on an organizational level. How can you undo racist structures that are in your organization just because they're part of our society? How can you be intentional about it in your recruitment, in your hiring, in your retention, in how you treat your patients, in your programmatic areas, and in your management. So we have some solutions that have come out over time, with our learning collaboratives, and we want to keep advancing that. The last area where I think it really is building on our strengths. One of the unique, really strong features of the council, and it goes back to what you said, Antonio, about those with the lived experience is that we have really tried to center the lived expertise of people experiencing homelessness. One of our three constituent bodies, one is for clinicians, one is medical respite care providers, and one is, we call it the National Consumer Advisory Board. Consumers is our term for our patients who have experienced homelessness that receive services. So they are right there. They have board seats. We have a minimum number of people of seats on our board reserved for people experiencing homelessness. We've exceeded that minimum target, but we want to make sure that all of the healthcare for the homeless programs are really listening and incorporating the expertise of their patients. Healthcare in general does a really bad job at this. It's actually the only field where I can think of that doesn't listen to its customers and then take it back. Instead, because they have the medical expertise, that seems to be we don't, if someone doesn't buy your car, you don't say, oh, there's something wrong with them, that they are service resistant or they are car resistant. No, I'm not bringing, my car is not good enough, or I'm not marketing it well enough. In medicine, or I should say in human services, we talk about service resistant clients. No. Our job has to be, how can we make the systems responsive to their needs? That's what everyone else does, and that's what we need to do in human services, in homeless services, in healthcare. And the best way is to listen to your customer, listen to your consumers, listen to your patients, and we want to take that further than we've taken it up to now.
Well, thank you for that. That was absolute music to my ears. I hope my team who is listening felt inspired by that, because we share those philosophies as well. And on behalf of my fellow Americans, not just my community here in Los Angeles, the work that you're doing nationally, I just want to say thank you. It's been a joy chatting with you this afternoon and hearing about not only the great work that you've already done, but the work that you're currently doing, and then the influence that you're able to have at the tables that you're at, because that really makes a difference. So again, thank you. And with that, I'm going to turn it over to Jet, who's going to talk a little bit about our gala, which we're very, very excited about. And then people who are on the call, please don't go anywhere, because right after that, we want to open it up for a little Q&A as well. Jet?
Thanks so much, Antonio, and thank you, Mr. Watts. I share Antonio's enthusiasm, especially about your remarks related to the need for people in human services and homeless services and healthcare to really focus on being responsive to their clients. That was awesome. I do have a couple questions, and I'm hoping for everybody in the audience that you might add more to the chat. But before we get there, we're tremendously excited that our annual gala is coming up next month. It's 3 weeks away. On October 21st, it will be hosted by Jana Lee Ortiz and Max Carver in the Zipper Concert Hall at the Colburn School in downtown LA. And we're featuring live entertainment, inspiring stories, a Changemaker Award, an honoree, and silent auction. We'll have a pre and post program outdoor reception with drinks and past hors d'oeuvres. And this year, of course, we're offering our guests the option to attend in person or purchase a streaming ticket. And everybody attending in person, will require proof of vaccination, and you'll be asked to wear a mask when you're inside at Zipper Hall. The button to get tickets on your screen is actually a live link to the event website. You can click it from here. And I think the next slide is our standard calls to action. We always want people to know there are many ways to support our work. You can make a direct gift to the trust, add your voice to our advocacy efforts, and just join our mailing list to stay in touch and find things out, like we have the CEO of the Healthcare for the Homeless Council speaking on the virtual community meeting. There's always fascinating information in our newsletter. And with that, for Q&A, the first question I have for you, Mr. Watts, our partners at LA Christian Health Centers have talked to us a lot about the need for funding for street medicine. And I feel especially privileged to have had a conversation with their CEO, Lisa Abishu, and our Senator, Sidney Kamlager, when the clinic was opening, about their current funding. And, the street medicine that LA Christian is providing now is funded really pretty much exclusively through Measure H. And then we're thrilled that Senator Kamlager's street medicine bill passed, and we'll be creating additional funding for those services. Could you talk a little bit about how that works nationally and what the needs really are?
Absolutely. And I will say I was honored to have started the first street medicine program in New York City from the lessons I learned from colleagues at the Council and the Street Medicine Institute. We were consulted on that bill and were able to give input, so I wasn't following it, so I'm thrilled to hear that it passed. And it's so important because there is no clear consensus across the country on, and a lot is it based upon states, but even within a state, it's not always clear. Can you bill for street medicine or not? And I will give an example. In New York, we worked with a number of different providers. My agency was one. Some felt comfortable interpreting the regs to say that they could bill for services outside the clinic. Others were not. So it's not, there's a lot of ambiguity. So that fact that there in California, you have clarity about it is so important. So I'll stop there.
Thank you for that. And I see that Dr. Tamashu Kenyatta-Jones, our VP of Health and Social Services, has a question for you. So I will go to him next.
Good afternoon, Bobby, and thank you for joining us. Antonio, I do share your sentiment about the service values that Bobby shares with us. One of the questions that I have for you, Bobby, is that I spent a lot of my undergraduate, but postgraduate and doctoral work in residency looking at racial equity issues amongst African American males, but also Latino males, to the extent to where we look at education, but also healthcare disparities. And so I was very pleased to hear that you talk about racial inequities amongst, as it relates to homelessness, but being more intentional about naming it by race. And so my question to you is that how do we continue to actually continue to examine, just both, as you mentioned, quantitatively, but qualitatively, the racial disparities that we see in permanent supportive housing. But as you know, we have this thing to where we've seen the school to prison pipeline, but now we're seeing the school to prison pipeline to homelessness, right? So we have this extra layer, and it makes it also nuanced and complex. So I wanted you to kind of speak more to that, and perhaps what are some additional ways that an agency like Skid Row Housing Trust, we could be more intentional in addressing racial inequities, but also that gender piece too, because I think that's very key as well.
Yeah, absolutely. And thank you, Dr. Kenyatta, for that question. I think one of the first things we need to start doing is to intentionally and consistently collect data by race, to disaggregate data. That is one of the things that we spent a lot of time thinking about at the Health Equity Task Force, but it's something I've, as an epidemiologist working in a health center, been thinking about for years. How are we using the data? One, do we have the right data? And then are we using it? So one powerful quote that I can't remember who says it, because I would love to attribute it to it, but I use it often. I believe I heard it from a subject matter expert who briefed the task force, is that missing race data is a form of racial oppression. And you can say what, missing gender language data, whatever, because the problem is then hidden and then it can't be addressed. It can be denied that it exists and you can't address it effectively. So I think that is one of the things. And just as an aside, one of the things we've been working with our members on is that they have race data, because some are have to collect it for as a health center, but how well are they using it? So we're sharing best practices of how some have used it to promote equity, to look at their differential outcomes by race, ethnicity, and language. So I think that is one of the key things, to really collect it. At the beginning of the COVID pandemic, only 10 states were reporting on testing and vaccination by race. So it was hiding the fact that there were huge disparities. We knew it anecdotally, but it wasn't being collected systematically. Now it is, and we can bring it into sharp relief, and then we can develop programs around it. I'll give an example of one agency that has supportive housing. One of our members, and I'm glad to say that Los Angeles Christian Health Centers and others on Skid Row are members of the council, that operate on Skid Row are members of the council. But this one is in Oregon, and they looked at their data. They have a very large agency, lots of programs. They looked at their behavioral health substance use program and saw that Latinx members were not faring as well. And so they developed a whole intervention based upon Latin culture, language, making sure people spoke the language, and they've gotten, so that's how a great example. They did the same thing, and they saw that those completing their job training program, African Americans were faring worse. So then they developed Imani House, and this is an organization, Central City Concern in Portland, Oregon. And so based upon that cultural values and staffing. So there are ways that we have within our power if we use the data. The correct data interpreted correctly will tell the right story and help us design the right intervention if we want to solve the problem.
Thank you for that. That's key and critical in terms of closing the loop, but also I think our Skid Row Housing Trust, we continue to say let's use data to make data-driven decisions, but also close the gaps and examine outcomes as we try to scale. So thank you for that. I appreciate it.
Sure. And just as I like the phrase data-informed decision, because as you said, there's lots of data. There is quantitative and qualitative data. We need it all. But that has to inform it. It can't, there are other factors that people know intuitively and coming together to make that decision. But yes.
Thank you so much for that. I have another question for you. We get so many questions about mental health issues as a pathway to homelessness, and find serving folks who've experienced chronic homelessness that whether mental health was a pathway or not, it is certainly mental health issues are certainly attendant to just the experience of houselessness. Can you help us understand anything specific that the council has done to bring light to that and advance resources for mental health treatment?
Yes, and I should invite people to visit our website. You just Google National Healthcare for the Homeless Council or nhchc.org. We've had some learning collaboratives around behavioral health, as well as some publications that are there. But we know that this is a big issue for our population. We know this is a big issue in medical respite, which is designed ideally to be for short-term issues, but most of the people may come in with a fracture. They need a safe place for that to heal, but they also have these long-term problems. So we're working on how can we develop resources and capacities to address those at the same time. The main reason why people experiencing homelessness, I don't believe it is because of mental health issues. And I say this because most people with mental health issues are housed. The main problem is that there's a lack of housing and support for those who need it. So it is a really big problem among a subset of our population, is one that has to be addressed. One of the things the council has always done, in our community has always done, and even before it was in mainstream medicine, was to talk about we have to address the whole person. We have to make sure that primary health care and behavioral health, mental health, substance use disorders is integrated well together. And that's what one of the key things we do, where we're learning from each other. I'll say we're such leaders in this sense that other health centers have asked us to share our lessons, which we're glad to do. But right before the pandemic, Healthcare for the Homeless program saw 4% of all patients in the health center universe, but we're providing 40% of the medication-assisted treatment services because we had identified the barriers, found out ways to overcome them, and to deliver that integrated care. It's so, so important.
I cannot thank you enough for the work that you and the coalition are doing, and it's thrilling to have you here. We really appreciate your making the time to help us learn more about your work and about these issues and the way it informs our own. So thank you very much for joining us today. We appreciate having you here. And Antonio, thank you as ever for moderating such a fascinating conversation and managing the conversation.
Thank you.
All right, we will see everybody next month. Thank you for being here.
Thank you, Jed. Take care, Mr. Watts.
And you too. Thank you. Goodbye.